Dr. Yoni Witten here, and this week we're talking all about back pain. Back pain is a huge problem. It affects hundreds of millions of people all over the world. Unfortunately, many of these people are creating and perpetuating their problems because of the sheer amount of bad information that's out there on the subject. Well, this week I got to sit down with Dr. Stuart McGill, a scientist whose work has produced over 240 peer-reviewed scientific papers. He also just so happens to be a clinician who works with the highest performing athletes on the planet. I can think of nobody better to set the record straight. He and I get into what's causing all the back pain that we're seeing nowadays, why the current approach for treating back pain isn't working, and what's the best solution for this problem. I really hope that you enjoy the interview. Let's get into this. Thank you so much for joining us. We're very fortunate today to have a special guest. Dr. Stuart McGill was a professor for over 30 years. He has a PhD in kinesiology. He's authored 5 books and authored or co-authored 245 peer-reviewed scientific papers. He is a unique hybrid in the field of back pain in that he is a scientist, a researcher. He actually built a lab and measured people, normal people off the street and up to the highest level of athletes to see what causes back pain, what causes injury, and what fixes it, most importantly. He's also a clinician. He has, in his own words, no political agenda, no medical associations. He's not affiliated with any drug companies or surgical appliance companies. He has no governments to appease. So what we're going to get from him is the raw scientific truth. Thank you so much for being here, Dr. McGill.
Well, good morning, Yanni. Thank you very much.
So what I wanted to get into right away is, why is what you do so necessary? Why do we have so many people with back pain?
Well, I'm going to have to backtrack just a little bit because you use the word back pain and people will think this is strange, but when you think about it, back pain is simply the report of a symptom. So if we played a little bit of a game here to give this whole thing context and replaced back pain with head pain. So if you said to me, well, why is head pain such a problem? People understand that you can't even begin a conversation about head pain. You need an assessment to start the whole thing to determine whether the person has brain cancer or a head cold or a concussion or whatever it is. So we have to begin the conversation of back pain to change it from a symptom into a subcategory that has a mechanism that then directs a very helpful discussion on causation, rehabilitation, prevention, training to become robust. All of those things require a very thorough assessment. We can talk about that assessment afterwards if you like, but that's what I spent my career doing, trying to understand the mechanism of the various subcategories and pathways to back pain. How would you then probe it to really understand that particular person's life? Is it their job? Is it their movement patterns? Is it something they inherited? And all of the influences that determine the course of how that mechanism plays out in their life. So that's the beginning of that conversation. And the second thing that comes to mind, which I don't want to offend people with this, but I'm just going to say, who is the back pain expert? Now, consider someone who's been in a car wreck and they've broken literally the bones and parts of their back. The surgeon really would be the expert there to go in and screw it back together again. Is the surgeon the best person for someone who has created a very specific type of disc bulge from a very specific type of offense to their back? Probably, well, absolutely not is the answer to that one. So uh, when you look at all of the various flavors of medical training, and we could put that in there: chiropractic, physical therapy, orthopedic surgery, neurosurgery, osteopathy, and I could go on down the list, psychology, etc. Not any one of them is trained to perform a thorough assessment that assesses anatomy, biomechanics, physiology, neurology, psychology, all of the personality, learning style, all of those features of the individual that will impact why they have the symptom of back pain.
Mhm.
So as you're aware, we had to begin the process of training our own people in all of those subcategories of expertise. So you need a little bit of medicine, a little bit of, can I read that person? You know, the very, I'm a little off topic here, but it's so interesting when you look at criminal behavior and how does that criminal know who their next victim is? Well, they can sniff out and see weakness, and
Sure.
they see it from a mile away.
Sure.
Well, every clinician should be able to see the pain in that person's eyes. They should be able to see the response when they're asking questions,
Yes, sir.
to really get at the forces, be they mechanical forces or social forces, that are impacting why that person has had these impediments that no one's been able to deal with to get rid of their back pain. So I could go on and on, but there's a little bit of a start on this, and we can talk about medical practice and all of the incentives and whatnot that usually aren't aligned with the patient's needs.
Very much so. To your point about being able to, for a criminal to pick a victim based on body language, posture, how aware they seem, all these different things. That was a skill that I developed, or was forced to develop, I would say, early on in practice, because when a patient comes in and they start talking, one of the things that a clinician really has to do is be able to filter into the right or the left side. This is important. This is not important. This is important. This is not important. And that's how you kind of phrase your questions. But I've on more than one occasion found myself being envious of veterinarians because you can just observe without the distraction of the words.
What a wonderful observation. My sister's a vet, and we have many conversations, as we have had for years, on I wish human clinicians would have the same philosophical training as veterinarians to determine how an animal responds to pain, how their posture changes to pain. You can see the victimization in the poor dog cowering in emotional pain and physical pain, etc.
Yes, sir.
But this has been lost. When I started almost 40 years ago now, I would say the orthopedic exam existed, and prior to the widespread use of imaging and that kind of thing, and docs really knew how to put their hands on, stress different parts of people's backs and hips and pelvis and determine what the pain source was. Now this is very, very rare to find this among clinicians.
Yeah, one of the things that you'll even see is if you ask somebody to do something that they are uncomfortable with before they even do it, they're thinking about performing, that will change their facial expression.
Yeah.
It's amazing. But I saw an interview that you gave where you talked about meeting with a very high level law enforcement director and your ability to conduct an interview, and he was praising your ability to kind of read his reactions and stuff. And so that I found that very funny.
Well, part of it is to extract information. And I remember that story. His job was, he was a professional interrogator. He was one of the chiefs of Homeland Security for the US. So when someone comes into the US that the Border Patrol is unsure of, they take them into the back room and interrogate them. Are they really a refugee and all the rest of it? But we studied all of these various techniques of how to extract information, and that's what you want. You want that patient to tell you things that they've never told the previous 12 clinicians that they've seen. If you're going to be the one who makes a difference, you've got to get at what the impediments were, and then go to your skill set to see what can you do to either eliminate the cause or mitigate it somehow, or hack your way around that cause.
Which
It's
goes back to what you were saying a minute ago about the person who's suffering with the back pain being the expert on that subject.
Well, there are some clinical trends that are a little bit disturbing to me. I think you're broaching on one of them, and it's the interpretation of a person's pain report. And to us, pain is what the patient says it is. If they have real pain, that's what we proceed upon. But there are many people now who are believing that pain is somehow magnified in their head, that there is no real biological cause, and that cognitive behavioral therapy will address it. And yet, I would say that when we show a back pained person how to repeat the task without their pain by changing their posture, or uh, something that we can coach them to do, is that cognitive behavioral therapy? Is it biomechanical based physical type of therapy? Is it a mobility that we're now, when you change posture and movement patterns, what ends up happening is you migrate stress from certain parts of your body to other parts of your body. So the key there would be to migrate the stress away from the tissue that's causing the pain. Well, I never know. Are we empowering that person so that, you know, everyone knows what PTSD is, post-traumatic stress disorder. If you get hit by a lightning bolt and you don't know where that lightning bolt came from, that is PTSD. If someone sticks a knife in your back and you bend down to tie your shoe, or you sneeze and you get an acute back attack that you're in bed for 3 days locked up, that causes PTSD. But when you can empower the person to show, here was the specific cause of that, let me show you. Sneeze, not down into flexion, which you prove through the assessment they have an open fissured disc bulge. Instead, you bulletproof that mechanism by sneezing upwards now.
Yeah.
Now that person is so empowered, their posture changes, that whole victimization stance and demeanor disappears. Well, is that a cognitive behavioral therapy when it was pure mechanical coaching? I can't answer that. It's all of the above.
Yeah. But it's like, how do you separate out the different parts of the elephant? It's all the elephant.
In a nutshell, it's good coaching, which is a rather rare thing. How many clinicians are taught how to coach?
Yes, you're exactly right. You're exactly right. One thing that I didn't share with you when we got started was I had 6 years of personal training and an undergraduate degree in kinesiology, where we learned how to coach in the program. So I had all that going into chiropractic school.
Yeah, it's astounding to me now when uh, I see certain subgroups within therapy who are just oblivious to coaching, and now they're going to get lessons from personal trainers. Whereas years ago, it used to be the trainers would be going to get coaching or educational components from the therapist. That's reversed roles,
Yeah.
which is really based on the coaching skill these days.
Yeah, one of the downfalls of my profession, I'll speak to, is that we had traditionally done things to the patient. It was a passive therapy, and that's a downfall because you disempower the person when you're doing it for them. You allow them to offload their responsibility for caring for themselves onto another person. And I believe that at a very deep level, fundamentally, you are not helping that person if you're not doing what you were alluding to a minute ago, where you're giving them that light bulb moment where they say, now I have a weapon in my back pocket to help myself, rather than my cell phone to reach out and call Dr. So-and-so.
Right.
So I agree with you 100%. But what I want to change the the way that I phrase the question. Instead of saying, why is back pain such a huge problem? So there are 1.5 billion people in the world with chronic pain, and back pain represents about a third of that. So why, I guess, why does the back tend to be injured? We don't have to specify the type of injury, but why does the back tend to be injured so often, to the point where 80 to 90% of the population will experience it at some point in their lives?
It depends on the subcategory of their pain mechanism.
Okay.
So we have to name one, and then I can use that as an example. So let me I'll go ahead and do that. And let's say it's discogenic back pain. So pain involving the disc of the spine. Well, the whole mechanics of the joint depend on good health of the disc. So if you've compromised the health of the disc, and I'll give some examples of that, that changes the facet joint load, it changes nerve root friction, everything changes after that, and it doesn't come back. So if you broke your leg, within 3 months, a bony callus would form over the break, and you're actually stronger in that place of the bone, and you get back to life. But when you damage a joint, when you tear knee ligaments, that sets off a cascade now, and that knee will suffer and go through a cascade that'll last 20 years. Well, backs are exactly the same. So, you know, insurance companies tell patients, you will get 6 weeks of treatment to cure your back pain. And if it doesn't resolve in 6 weeks or 8 weeks or whatever the statute is, the pain must be in your head. But they trick people. They use data that was done on rodent muscles, rat muscles, and rat muscles heal very quickly. They have nothing to do with changing the mechanics of the joint from disturbing the disc. So let's take an example. Let's say a person does a heavy deadlift, heavier than they really ought to, or what they're currently capable of. The bones of the vertebra are filled with little microtrabeculae, small network of bones. They sustain microfractures, but the person then does another deadlift in a few days, and then another deadlift, and then those little microfractures accumulate. Then the collagen fibers that make up the disc, where they anchor into the vertebra, become weak because of the microfracturing, and they pull out a little bit, and then pretty soon the person starts bending, doing heavy squats, for example. Now all of a sudden the collagen starts to delaminate, and now they've got a disc bulge. So anyone who has a disc bulge, it just didn't come out of thin air. There was a very specific pathway that led to them getting a disc bulge. It was preventable. Maybe it's their job, but it's a combination of the way the person moves coupled with the load. So now they get a disc bulge. Well, if it's a focal disc bulge, it shrinks and grows. It shrinks and grows based on your activity. And we used to measure this when I was at the university. It was interesting that students would come to the clinic in exam time with open fissure disc bulges. That was their subcategory because they were sitting longer than normal studying right at exam time. And you could watch it go term by term.
Amazing.
Yeah, so sitting, the more they sat, the more pain that they got. But during the term, when they wouldn't sit so much, then they'd get up and walk and move around. That caused the disc bulge to shrink back a bit. So there's just an example of a specific subcategory to explain how it shrinks and grows, but wouldn't it be powerful for that person to know exactly what the mechanism was, and now they know why, if they're going to sit and they have that open fissure disc bulge, they should probably use a lumbar support when they sit. Don't sit for very long, and then do interval walks throughout the day, et cetera, et cetera. So they have a strategy now. They're not curing the open fissure disc bulge. They're making it subclinical, and that's the key. So nature over the next 10 years will gristle that particular open fissure, and they will become resilient, and they can violate biology a little bit once again, and they won't pay for it. But in the meantime, to keep it subclinical, they're going to have to follow some rules. So there's just one example of a very specific pathway with a very specific strategy that we've proven can reduce repeated episodes, and then that chronicity goes away. In fact, it never was chronic back pain. What it was mini acute attacks all day long, over and over and over. So they believed they had acute back pain. Stop the mini assaults, and the acuteness goes away.
Yes. And yeah, that's a very interesting way of putting it. And I'm glad you brought up the study that you did about students studying for midterms and final exams. In your opinion, if we take discogenic injuries for the example that you just used, so that I'm not speaking in such broad terms, have humans always been predisposed to those types of injuries, or is our modern lifestyle in line with what these students were doing, studying for examinations, predisposing us to a lot of these types of things, just based on how we're living now with our heads down in the phones all the time, working at computers, less movement throughout the day than ever before, especially with what's been going on in the world over the last year and a half.
Right. I get asked that question a lot, and I don't have a great answer for was there a lot of back pain 100 years ago, because I wasn't around to measure it. I've tried to study documents, and I just can't get a reliable measure on the incidence or prevalence of disabling back pain from 100 years ago. But it's so interesting. You can go on YouTube and watch scenes from the streets of New York or the streets of Paris around 1900. And it's striking. I would have thought that there'd be lots of people who are disabled. There's no hip replacements. There's no knee replacements. Where's all the people walking around on canes? You don't see them. Now, maybe they're just at home and they don't go out. But the people, it's incredible to see people in New York City striding along with beautiful posture. You do not see poor posture in 1900 New York City, nor do you see it in Paris or some of these other old YouTubes, which are so interesting to watch. When I look at native cultures today, I don't see the bad posture, the physical disabilities of being overweight, grossly overweight, waddling with, you just don't see it. So I don't know what the pain was 100 years ago, but you certainly don't see the disability in those clips. Yeah. However, we can go back to company injury files, for example, and there's no question. So I was at the university active as a professor for almost 35 years. The first year incoming class, we would teach them how to assess different variables of fitness and all that kind of thing. And part of it was they did a fitness test on themselves, and we taught them how to do that. And it was unique in that we measured movement quality. So we know that if you squat and the knees buckle into like a knock knee or a valgus position, that is a fairly strong predictor of ACL damage later in life. We know certain spine movements are linked to problems later in life. It's kind of like smoking. You don't get cancer for the first, and that was why they struggled so much to prove the link. The cancer companies got away with murder literally for years because of the delay of cancer from the exposure. And back pain is exactly the same. You have to study it longitudinally, control the exposures and incidence rates and those kinds of things. Anyway, getting back to our incoming class, it was so interesting. The students who grew up with computers and the incoming class right around the year 2000, the fitness level just dropped, boom,
Huh.
right down. And they came in much heavier and moving much more poorly. And it was linked to personal computing.
Yes.
Now, my job when I started at the university, it was funny. Computers weren't invented yet. We didn't have computers in the laboratory. When a professor retires, they give their last lecture, and I showed a little bit of a history, and the students in the audience came up to me afterwards and said, "Oh, you started in 1985 with no. How did you do your work?" And I thought, well, let me show you how we used to measure back pain and things back in those days. But anyway, getting back to, and then a curious secondary phenomenon occurred, and it started with the advent of the personal trainer and YouTube. So the students en masse got heavier, moved more poorly, and more unhealthy, shall we say, less fit. And then it diverged again with training programs on YouTube and personal training and that kind of thing. And the unfit became even more unfit. But then a resilience came in a second group, and they were typically overtrained.
Oh, interesting.
So yes. So now we had another diverging mechanism of back pain. So when you train, what you're really doing is stimulating your body to adapt. So when you strength train, you tear down the muscle, it adapts over the next few days as you fuel it with food and you rest it and that kind of thing. But if every day you weight trained, you would develop orthopedic problems as the cumulative micro trauma grew, but you never gave the time to rest and adapt. Well, you were training to adapt anyway, but someone forgot to tell them you got to leave time to adapt. So do you see that subcategory of back pain now, the overtrained, the exercise addicts
Yes.
versus the undertrained who were the sitters? They
Mhm.
were the ones who were movement adverse,
Yeah.
and they had quite a different series of subcategories of back pain. So anyway, that was a little bit of a history lesson, I suppose. I wish I could go back to early 1900s or even the 1700s. But just as a point of issue, Yanni, you might find this interesting. There was a show in England where they were contacting so-called experts around the world, and the show was, let's redesign the human body and make it better. So they got a kidney specialist, a heart specialist, and I was the guy they called about the spine, and they said, if you could redesign the spine, how would you do it? And they called a knee guy, etc. Do you know, I don't know if they ever even made the show, because at the end of it, every single expert concluded that the process of evolution and natural selection worked. We already are optimal. So let's take a whale. A whale drives movement with the big fluke with a lot of motion. But the whale doesn't have to deal with gravity. It's a huge animal suspended in the ocean. They have a ball and socket joint. So when you look at the bones of the tail of a whale, you will see a socket and a ball. And that's how they drive the fluke motion around a ball and socket joint. But can you imagine if our spine was a stack of ball and socket joints, you would need a massive musculature like a whale around you, because it'd be like stacking 20 oranges on top of one another and putting a book on top. The oranges would fly apart, so you would need a massive guy wire system to control and support a ball and socket system of the spine. I've got another model over there that is ball and sockets, and it's virtually impossible to control. So what we did was we developed discs, and the disc adds a stiffness and a control to the movement. So you don't need massive muscles. So when I stand and talk to you now, I can stand and hover with zero muscle. And in fact, there are people who have a subcategory of back pain that they're overly stiffened and they're just crushing themselves all day long. And we have to say, look, calm down, let all the tension. And so their back pain begins with breathing exercises and relaxation exercises. The next person is an absolute dead fish. You shake their hand and you can just tell there's nothing there. Squeeze my hand, and they squeeze as if, you know, come on, I need some constitution, because when they pull on a door, their back falls apart.
Yeah.
Do you see? And then the next person is so rigid, they pull on the door and they've crushed themselves already. But anyway, the discs were this wonderful adaptive structure that adds beautiful stiffness, but it has created another category of if you have too much motion with too much corresponding load, in other words, doing deadlifts with bad form, chances are you will start to delaminate the collagen, and then over time you will pay for it.
Yeah.
So, and anyway, there's a little bit of a thought of going right back to our evolutionary ancestors with that back pain question. But there's no question our body has to follow rules, biological rules, because we live in this linkage and we have certain joints. Ball and socket joints are made to develop power through a range of motion. Your spine joints are not one of them.
Yeah.
They are made to have a certain amount of stiffness to allow you to be very efficient in relaxing and moving around through daily life. It allows you to bend over and tie your shoe, but then it allows you to stiffen it, position it, and pick up a heavy log.
Yeah. Amazing structure.
It's an amazing structure, and I couldn't design it any better.
Yeah, I was going to say that takes quite a bit of nerve to be the person who steps up and say, I'm going to do this better than millions of years of evolution.
Well, you know, it's interesting. A non-spine expert will.
Wow.
A
That's cool.
non-knee expert will come up with a better design. Engineers are coming up with designs all the time for body parts,
Yeah.
but they've just been to engineering school and
Yeah,
they don't understand human function just yet.
yeah. Yeah, that's a nice way of putting it. I wonder if you can speak to the discrepancy in the medical literature between you have tons of medical journals out there, very well respected journals, saying things like essentially they give the impression that back pain is no big deal. They're very dismissive of it. They say back pain goes away in 2 weeks, back pain goes away in 4 weeks, or like you're saying, the insurance guidelines, 6 to 8 weeks, or it's in your head, versus American Journal of Medical Sciences says that we have a relapse rate of 85% among these people. So how can it simultaneously go away in a matter of 2 to 6 weeks, say, and have an 80, it's not going away if it's coming back 85% of the time. So how can those two things coexist? Are they just looking at different time frames, or what's going on there?
I think when people make conclusions of it, it's quite often people who are not spine experts. I hate to say that, or they have a very unidimensional view of back pain. Now, I know there are some scientists who work for insurance companies, for example, and they will, for various reasons, state that back pain will cure itself in a very short period of time. That's what the science shows, but they're very misinterpreting the data. As you point out, the recurrence rate is very high because the mechanism isn't cured. The mechanics have temporarily changed. Let me give you an example. So let's take this spine model. It's very highly biofidelic. There's a company in Canada, actually, Dynamic Disc Designs, that makes these things. So we see the nuclear gel inside the disc. So the disc is a hydraulic structure. So the hydraulic structure allows movement, and it supports compression and shear and bending because the middle is a gel. But now let's overuse that particular structure and we start loosening the collagen. So my shirt is a fabric. I can create stress strain reversals and I will delaminate the fabric. Well, the disc of the spine is a adaptable fabric. That's the category of material science that it falls into. It's fibers of collagen holding a gel nuclear disc inside. But if I overuse the disc, I start to delaminate the collagen, just like the fibers in my shirt. And then when I pressurize the nucleus, do you see the little red mark on the end of my finger? Watch. Do you see it opening up now right here and the gel squirting out the back, or not squirting, but bulging? There is the nerve root that's typically there. It presses on the nerve root and causes the back pain. Well, if the person that will last, by the way, that gel, when it comes out, now I have to get into ontological development and neurodevelopment. That disc is fused up inside the fetus around the end of the first month. It's the day that neurulation occurs. The fetus has not received an immune system from the mother yet through the placenta. So the very first time that nuclear gel comes out, it sees the environment with blood and antibodies. It sets up a massive inflammatory response, and it creates an inflammatory soup, as you know. And now, as the person moves, when they look down and they pull their leg, these nerves migrate back and forth like this. When you pull the nerves through the inflammatory soup, it causes a lot of problems. Sciatica causes their toe to go numb, and all that kind of thing. It takes 4 or 5 days for that soup to clear out. It takes 4 or 5 days of not sitting at your computer, but walking around and doing therapy for that disc bulge to resolve. It's gone away. So the scientists will say, oh, the back pain went away, it's cured. No, it's not cured. It just became subclinical. The delamination is still there. So the next time they think of the triggers that people will report, and your audience will relate to this. When did you hurt your back? Oh, I hurt it when I was out of position and I picked a pencil up off the floor, and that was the straw that broke the camel's back, or got that inflammatory process all angry again. They stirred up the hornet's nest, or they were gardening for 2 or 3 hours. That will settle down. So these things, back pain doesn't come and go because it's cured and then it gets re-injured. It becomes clinical and subclinical. Let me show you one more very powerful model, Yanni. With disc injury, think of when you tear ligaments in your knee. The knee becomes unstable. So if you did a drawer test on the knee, there would be laxity there, and it may trigger pain. Your spine is exactly the same way. Consider when you get when you let a little air out of your car tire. The tire bulges, and now the car drives very sloppily on the road. It's not in control. Your spine is exactly the same. So consider this disc is normal. The bottom one is normal. This is the one that has had a little bit of damage and it's lost its turgor. Now watch. I'm going to bend one way. Do you see where the majority of the motion occurs? It occurs at the joint that's lost stiffness. Now, look at the micro movements, look at the movements on the nerve roots, look at what's going on at the facet joints on the side where the laxity has occurred. That loss of stiffness in that joint changes a lot of things going on about that joint. So the person can irritate those nerve roots, set up an inflammatory response. They've got 3 or 4 days of a very acute back attack. The spine splints, locks it up, it settles down. Let it be. And then the next week, they're pretty much asymptomatic, but they're not cured. The next time they offend those micro movements, they have another blow up. So every 3 months, they have this repeat of the pain acute stage. The mechanism's exactly the same, and it's never cured. Once we detect that with various tests for what we call clinical instability and loss of stiffness, we then empower the patient, as you know, by giving them stiffening types of exercises, showing them movement hacks on how to tie their shoe, how to get on and off the toilet, in and out of their car, or even, as you know, one of our subspecialties is to restore high performance athleticism. How do you squat 1,300 pounds after a history of micro movements?
Wow.
You better get it right.
Yes, sir.
So Brian Carroll, as you know, earlier this year, after a very massive back injury, came back and set the all-time world record of squatting 1,306 pounds. It's astounding.
Amazing.
But anyway, there's a little bit of a start. How many people truly understand those mechanisms? You don't get it in medical school or chiro school or physio school.
Yeah.
It took me 100% dedication for 40 years to try and obtain some understanding of all of these fields coming together to create the symptom of back pain.
Yeah, you phrased it beautifully there. So what I think that what's at the root of all of that is kind of a misunderstanding on the part of the person who's reporting those stats, that it's been resolved because the pain has gone away. So what I would ask you as leading off from that is, what's wrong with the diagnostic approach that conventional medicine is using for these problems, where they could even say such a thing like, oh, it's resolved. No, you don't need to worry. You don't even need to treat it. A lot of these journals are saying, they're just saying, cover up the symptoms for a few weeks, do some palliative care, and then pain goes away and all is right with the world.
Well, I think the key is they didn't do an assessment.
Okay.
So what are the impediments to getting a good assessment? Number one is you've got to find the person who has the expertise. Medical schools, they start with, just to become an MD, it's 4 years of intensive training. They might get 2 hours on assessing back pain. So it would be a straight leg raise and a couple of other things, which are highly non-specific and don't reveal anything about the mechanism of back pain. So to find someone who really can assess the mechanism of the person's pain is very rare. And as I said, I've spent a lot of effort training a few, and there's a few around the world, and they're on our website. I do get asked to go to medical institutions, different universities and whatnot. Would I see 3 patients on a stage? They just want to see how my brain thinks to assess an individual, and they'll say, we don't think like that. We've never seen anything like this before. So that's the first major impediment. The second major impediment is the medical system itself. Clinicians perform things, interventions that have a billing code. If it doesn't have a billing code, they don't perform it. So you show me one billing code for a thorough assessment of back pain. They don't exist. So there's no experts who perform that for a billing code. So what we do is we charge for the hour, and or I should say for the time, because some of our assessments will take 3 hours. 3 hours it takes us to unravel why this person has failed every previous attempt to deal with their back pain. The next thing is it's corporate pollution, I guess, is probably a way to term that. Every clinician should know their success rate, and none of them do. The only clinic, when I started the experimental back pain clinic at the university over 20 years ago now, one of our rules were that we had to follow up with every back patient who ever came after 2 years. How did you come along? Did we help you? Did we hurt you? What was the subcategory of your pain? Did you even comply with what we suggested? A really detailed inventory on success. And I don't know of another clinic in history that's done the same thing. Wouldn't you think that an insurance company who pays for back pain would know how good the people are who work for them?
Yes.
They haven't a clue. They pay for procedures that are known to make people worse on average, and yet they don't ask for the efficacy rates. So, but there's a real convenience. I remember Al Gore's, remember his documentary, The Inconvenient Truth, that was about climate change and whatnot. There's a very inconvenient truth about back pain, and it's exactly the same. In the US, there are surgeons who make tens of thousands of dollars, many tens of thousands of dollars for a single complicated spine surgery. I've seen them do surgery for things that never ever were a surgery case in the first place. But what's the incentive? They made tens of thousands of dollars to make that multi-level fusion with a mobility hardware at this joint, a stability hardware at that joint. The efficacy rate it just doesn't warrant it. How many disc replacement patients can you say, boy, they're really happy? They can really do what they want now, when they had a chance of doing that. So there's this real disincentive for certain procedures and people coming along with conservative care. Or they'll be told, well, you've tried all the conservative approaches. The last thing left for you is spine surgery. Wait a second. What was the conservative things that you got? Oh, well, I went to the physical therapist and they gave me ultrasound. Didn't work. Well, wait a second. Or we did stabilization exercise and they told me to suck in my belly, activating transverse abdominis. Come on. We know that these things aren't efficacious. So that's the next thing. The insurance companies have got to start justifying their payouts. And it's also very convenient for insurance companies, for compensation boards, to get people off the liability payout rule. So if we're paying for your compensation now, you don't get better in 3 months, we're going to send you to work hardening, for example. And you have to make these benchmarks every week. Well, hold on. Biology doesn't work that way. Some people are very tolerable and it's successful and they get them through. Other people, they take longer to adapt and get rid of the pain. So the insurance companies just break them down. And then they're called non-compliant. Oh, you're non-compliant, but the person is in so much pain. I've had some of those people who've gone to work hardening where they became disabled. Yes. With them. Yes. And it's, what the heck is going on here? But it was convenient for the insurance company to label them non-compliant because now they can kick them off the payroll. So where's the person? They don't have any money, and no one showed them how to deal with their specific mechanism.
Yeah. Well,
It doesn't it break your heart? You know, it's emotional talking about these things.
it absolutely is. And there was a few quotes in your book, Back Mechanic, that really stuck out to me. One of them was, even when a diagnosis is reached, such as sciatica or a disc bulge, for example, it's not helpful in terms of finding a solution, which is
Right.
another factor. Because even when they're coming up with it, they're given this label, and then the patient doesn't know what to do with that label, because it's not a constructive label. It's just, this is what you got, and often
Yeah, give me an exercise for sciatica. They don't exist. We've got to assess the sciatica and determine, if I go back to, where's that model? If I go back to the model, sciatica is pain running down their buttocks and down their leg. If the offense on the nerve root is underneath, so when they do a slump test, a typical physical therapy slump test, and that causes their sciatica, we'll give them a McKenzie exercise, for example. But what happens if the nerve root is underhooked this way? So when they lift their head like this, that gives them their sciatica, because it moves the offense down into it with an underhook. So it depends. It's great precision is required. Is it underhooked? Is it overhooked? You don't need a medical image to determine that. It's usually a seated test, and you play with the nerve tensions and figure out what causes and triggers the person's pain. These are quite simple things to do if you understand the mechanism, and then all of a sudden you can then realize, well, if they did a prone tummy lay, and instead of propping the head up in extension, allow the neck to flex and the low back to extend, now you can decompress the disc and take the pressure off that underhooked nerve root. But when I hear, conservative therapy didn't work, they went to a clinician that realized, or didn't realize, we live in a linkage.
Yeah.
And I know what you do, Yanni. You know this. Certain parts of the body in certain types of movements need to be stiffened and controlled. Other parts of the body then become responsible for the movement. Well, if through injury, if you've injured or for some reason have a stiff left hip, if you do a rock back test, you'll see right away that stiff left hip goes into a stressor in the spine. So if you can't tune the strategic mobility and stability throughout the linkage, you will get stress concentrations and pain, just like the operator of a backhoe who sets down the stabilizer bars into the ground and then uses the arm to dig earth. If you froze the elbow, the machine will break you. It migrates the stress to another part. So even a machine operator knows back pain more than many clinicians who don't understand how to tune a body.
Well said. Well said. One of the other quotes that I love from your book was, quote, "Instead of focusing on the title of your condition, we must turn our attention to finding the cause of the symptoms." Powerful, powerful, because people will come in and say, I have sciatica, I have a disc bulge, but those terms actually don't mean anything.
Well, they do a little bit, but it starts to say, okay, well, there's something there that needs a lot of assessment to give you a very precise plan to stop the cause or hack your way around it. And that could be a ergonomic kind of approach where you can change your job or certain aspects of it, at least the physical characters of it. Getting just a simple sit-stand table may help some people with hip and low back issues, as an example. Or it might be something that some internal exercises that they have to do, or it may be simply the first thing you have to do when you get out of bed is go for a walk. Yeah, don't go and get in your car. Go for a walk. Every time you put food in your mouth, you now commit to a 10-minute walk. Simply that will help de-stress the stress concentrations in certain subcategories of back pain people.
Sure. But when you hear sciatica, there's I think, a general misconception amongst the public that it means a specific thing, but you can have sciatica due to a disc problem. You can have sciatica you can be one of that 15% of the population where the sciatic nerve pierces the piriformis, and you can have a muscular issue or scar tissue built up that's pinching it. I mean, those are two completely different things. And I think it almost does it a disservice to call them by the same name.
Right. It could be an arthritic concern. It could be a cancerous tumor. It could be, oh, it could be a Tarloff cyst that's grown on the nerve root. Yeah, it could be any of these things, of course.
Sure.
And a lot of them won't get better in 6 weeks.
Well said. Well said. So that leads us right into what's wrong with the current treatment approach that the conventional medical doctor. So we have hospitals in the US, at least, I know you're in Canada, that are being run by MBAs at this point, and it's being run like a business. And we have a population of people with a lot of health problems, and they're seeking assistance, and the medical system doesn't have time, or as you alluded to, the knowledge and the skill level to properly assess these people. And so they get a kind of standard prescription, which is, non-steroidal anti-inflammatory drugs generally right out the gate, and some form of muscle relaxants, and then a recommendation to rest or immobilize the painful area. I call it the clinical dismissal. Most of the time, they don't have a specific diagnosis. As you know, they come away with, I've seen some documentation that shows that over 90% is coming away with non-specific low back pain. And I saw a wonderful presentation that you gave called "There is no such thing as non-specific low back pain." So can you speak to what's wrong with approaching it that way?
Well, I don't know if I can say too much more than what you've already said. There is no, if someone has non-specific low back pain, it means they haven't had an assessment.
Okay.
So make it specific and develop a strategy to wind down the cause, desensitize the pain, build a foundation through adaptation in the body for a certain amount of pain-free robustness, and then the fun begins. What do you want to do? What are you passionate about? Do you want to play with do you want to be the most rocking 75-year-old grandmother or grandfather for your grandchildren? Is that your goal? Because I can give you some clues on how to get there with no back pain, or, no, my goal is I want to win the UFC. So, I'm a jiu-jitsu fighter. And so, we have the full spectrum, or they make many millions of dollars in the NHL or the NBA or whatever it is. Or maybe it's just, look, man, I'm a firefighter. I've got 3 little kids. I've got to get back to work. I've got to feed them. So it depends. But anyway, how do you rebuild a firefighter? How do you rebuild an NBA basketball player? How do you build a stay-at-home mom whose passion is yoga? Well, there's a way to do it. So it all comes from the assessment, and there's various levels of the assessment. Once you get to that stage where, okay, by and large, I don't have back pain anymore. But if I go back and re-offend the original mechanism, I'm back to being a back patient again. No, we have to stop that, and we have to proceed with that. Creating your passion, the last part of getting your life back. There's a real science to it, to understand and go and measure what are the demands of yoga or NBA play or fighting in the UFC or being a firefighter. Then go assess the person. Can you meet those demands? And maybe on 5 of the demands you can meet them, 3 of them you can't. Only train the 3 things they don't need. Why waste all the capacity on the things they can already do well? But that's a huge mistake. People train what they're good at. And then we rebuild the things that they need that they don't have in a way that doesn't reoffend the original trigger, and in a way that makes them more robust. And that's the fun of it.
Yes, agreed. I always think of it like a canvas. you spend that initial stage kind of digging the person out of the hole that they're in and getting them back to a blank canvas. I talk about it like taking this canvas that already has paint smears on it and you paint it white so that then you can do whatever you want with it.
That's a nice analogy.
But I love how your face lit up when you said now's when the fun begins, because once you've dug them out of that hole and they understand some things, and what you're saying and what I'd love for you to get into next is desensitization, because it gets lost somewhere along the way, I think, for a lot of these chronic pain sufferers, that the pain is intelligent. Their body is it's giving them very important information. We kind of set up this adversarial relationship with pain instead of an understanding relationship with pain of what is this telling you and how can we use that information to course correct and get you on a more sustainable path.
Right. It was so interesting. I've been retired from the university for 5 years, but I'm in BackFit Pro HQ here in Canada, and prior to the pandemic, people would fly in. I've just been doing virtual consults since that time, but my point is, when I was at the university and an insurance company would either send a person or a person was in litigation, the first thing that they did, and you could see it a mile away, was to prove to you how disabled they were and how much pain they were in. And they wanted me to sign the documents to keep the disability going.
Well,
And I said, well, I don't play that game. I said, what our mission is to get you out of pain.
mm-hmm.
Are you on board? And believe it or not, some people said, no, I'm not. I said, then I'm not your person.
At least they were honest.
Yeah, but so was I.
Yes, well, I'm glad you went.
I said, I am not your person, because my job is to get you better,
Good for
no
you.
matter what. So, I'm sorry, but there's the door.
Yep.
Unless you're on this 100%, because I need every fiber in your body. Because here's what's happening. If I take a hammer and I hit my thumb with the hammer, it'll get a bit angry. If I do it the next day, it becomes really angry. And then by the third day, I don't have to hit it with a hammer. All I do is lightly touch it and you will scream. That's called central sensitization. Do you think giving them exercises or more work for that thumb and keep hitting it with a hammer will get it better? Of course not. The key is to take the hammer away. And that's what desensitization is.
Let me stop real quick, Dr. McGill. Why does the body become more sensitive?
I am not going to get into a very complex discussion of what really the mechanochemical neuro pathway of pain is in the brain. So I don't need to go there.
No, I'm just saying, why would the body speak louder to the person as the insult continued?
Well, in the spine, you're accumulating damage. Mm-hmm. Now they'll say, well, the MRI doesn't correlate. Wait a second. When I do a micro MRI and a micro CT followed up by micro dissection, I'm measuring the damage. It's there. It's just that they don't have the technology to see it in an MRI. Or sometimes you can, and the radiologists ignore it. The edema is starting to form. You can see that in the difference between the T1 and the T2 and the STIR imaging wavelengths. And so it's there for you to see. You're building trauma.
Yes. So as the situation becomes more critical, the body will speak louder to the person to try and get them to listen. Is that accurate?
Most of the time, yes.
Okay. So when I interrupted, you were saying if the person's hitting themselves in the hammer with the thumb and I give them exercise, if you could give them the best exercise, the most appropriate exercise in the world, but as long as they continue hitting themselves in the thumb with the hammer, the pain will continue.
Correct. Now that hitting themselves in the thumb might be the inability to move well at another joint.
Yes.
So now they're forced. So again, if that's the case, it comes back to we've got to tune your linkage, your body.
Sure.
If it's sitting at the computer for 8 hours with their job. They sit in their car, they come home, and then they watch TV at night. I just look at them and say, you deserve your pain. Your spine is not made to withstand that amount of static sitting. If you continue that behavior, you deserve your pain. I can't help you.
That's a powerful statement.
Well, I'm old school,
I like it.
and we get to the truth, and sometimes the people cry, and I say, but that's part of the process. If I simply can't help you if you think you can sit your way out of this pain. If you have lazy, slothful behavior, and at your very core, that's what your constitution is, we've got to change that, because you are paying for it with pain. Then you get the opposite kind of a person who is, again, the exercise addict. I've got to go and ride the treadmill for 45 minutes every day. Otherwise, my kids will drive me crazy. My husband is, I'll murder him if I don't release my tension that way. And I say, okay, we need a replacement strategy. And, but I can tell you this, then we play the game that I call virtual surgery. You go have surgery, but the surgeon cannot cut out that type of pain. So the surgery will work if it does, because it's for the first time forced rest. We are forcing you aren't going to go back on the treadmill tomorrow if you have a laminectomy. You're going to rest in bed. You're going to get up and go for a pee, and then you're going to go back to bed. But guess what? That's what we're going to do. Starting tomorrow, we're going to desensitize your pain and treat you like a post-surgical patient. I have an incredible statistic for you, because I ran this at the university. 95% of the people will get better and avoid surgery.
Wow.
So that's an incredible. Now, wouldn't you think the insurance companies would be interested in that?
I would think.
Why don't they pay for that?
Yeah.
Yeah, it's an eye-opener.
Yeah, you have a wonderful quote. I keep talking about your book, The Back Mechanic, but I think my favorite quote in the book is, what you don't do is just as important, if not more, as what you do.
I guess when I'm writing it, sometimes the words come together well.
That was fantastic, Dr. McGill, because not a lot of time is spent in school talking about that stuff. And you don't get it in these fancy medical dramas on TV that everybody's locked into. It's not sexy for the clinician to be the voice of reason and for this person to come in and say, like you were saying, I commute to work, I sit for hours, then I commute home, then I sit in front of the TV. And you say to them, well, you deserve your pain because you are training your body into pain. I had a conversation with a colleague of mine who's a physical therapist who works with triathletes who are very much towards that end of the spectrum of the over exercising that you were talking about. And we were having a conversation about a patient that he had who had a knee and ankle injury. And he said, what would you do? I've tried everything and it doesn't work. I said, take the patient off of running. And he started laughing. He thought I was joking. And I said, I don't see what you think is funny. You have zero chance of getting that person better if you don't stop the insult for a period of time and then rebuild them.
Right. Yeah, unless you're, this has been an extraordinary year for several reasons, but, we're winding down to the Olympics now. So, my work with that whole group, it's pretty much done. But if one of them were to come to me today and I say, well, what's our time constraint? Or, I've got one fella who's worried about the NFL draft. The next guy has a fight in the UFC in 5 weeks. If you have a time constraint like that, now we have to dance the dance just a little bit of not going to the biological tipping point of really creating more pain and damage, but we've got to get up to that, and that's a real trick. It's an art and a science, as I call it. But if you're not being paid $1 million there's not much of an excuse to take that time off. And when an athlete needs a total rehabilitation, take a year off. And that's what will be required. But we've had some fabulous success stories in high profile sport where the athlete has taken a year off and really allowed a foundation, a constitution to be created, from which we then say, okay, now let's get back to having fun, and we're going to build you back slowly and progressively. And it isn't about strengthening your back in the beginning. It's about moving well and getting some of the patterns. Just lift, if it's so interesting, Yanni, when we go back to different training cultures, which I studied a lot, the Russians were so clever. The Eastern European training philosophies were light years ahead of the, some of the blood and guts American philosophies based on passion and working harder and that kind of thing. Whereas to bring along an Olympic lifter, they would force the young lifters to lift broomsticks until they could lift with perfect form. And then when you could lift a 10 out of a 10 perfect style lift, you could add 5 kilos to the broomstick, and then get another 10 out of 10 perfect lifts, and then you could add another 5 kilo. In the US, I'm not dumping on the US, it's just a contrast in styles. But what do? They take a strong kid and they give him a bar and say, go. Wait a second. What happened to those years of grooving in the perfect form? So if they have a couple of bad lifts, or they're under 500 pounds now and they make a movement error.
Yeah.
What do I do? I've got 500 pounds on my back. Do I correct it with my back? Oops.
Yeah.
Just went.
Yeah.
You just damaged it. Now you're in pain. Versus, oh, I remember I've got that perfect form back in my muscle memory. If I just push my toes a little bit, now I corrected. I got that 2 millimeter error in my line of drive through the bar corrected, not by a spine strategy, but I did it with my hips or my ankles or my toes or my knees or whatever. So yeah, there's a real, and I will also say that the general development of athleticism is in different cultures more valued than the specialization that tends to be an American culture, where I'll get a young athlete here with the parents, and they've flown up, and the dad says, "Oh, we're going to the next championship up here." I said, "Sir, it's not we.
Yeah.
It's your son. So I don't want to hear we. All you do is pay for it. It's not your body." But then I hear the story, and then he says, "And we on Mondays we have the strength trainer who comes over and does this, and on Tuesdays we have the technique trainer who does this, and on Wednesdays we have the massage therapist. On Thursdays we have, before we do strength again, we have the sports psychologist." And then I look at the kid and I say, "Son, can you tell me when your last day off was?"
Whoa.
And the poor kid is silent.
Yeah.
And I just have to pause for a minute, and I'll say, I don't know of a top pro athlete who can't remember their last day off. It's very strategic, your work day and your rest day. It used to be called Athletes Performance. It's now called Exos, but the whole operation run by Mark Verstegen. When you go into the gym, there's a sign over the door, work. When you leave the gym, there's a sign over the door, rest.
Brilliant.
And it isn't that brilliant? And and then the whole conversation changes. I don't need to hear any more of what you're doing to build your son, or at least you thought it was building him, because you're actually tearing him down. Let's develop a strategy to rest your son.
Yeah.
Or your daughter. And that's very person specific, sports specific, maturity specific, etc.
Yeah, yeah,
But oh, the conversations you have, and sometimes it's more with the parents than with the athlete of a young athlete who's just, and the kid doesn't have a chance of making the pro leagues, and they're
oh, that's
just
brutal.
being, yeah, they don't have a chance. I can see it a mile away.
That's brutal. That's brutal. But
Yeah.
it does contrast Eastern and Western philosophy a little bit, where I have some background in martial arts, and we would spend months in the beginning just learning how to fall properly.
Oh, of course.
Just building that foundation versus, I'll see high school athletes at my clinic who are encouraged to join the 400 club. They're 15, 16, 17 years old. They have no business lifting or pulling that kind of weight. And, they've been working on their foundation for less than a year or 2 years max, and they're encouraged to join the 400 club. I mean, they're setting these kids up for failures. Disaster.
Oh, trainers do it all the time. And you go to gyms and you see who's on the record board, and you wonder why you keep getting patients from those operations.
Yeah. So I would like you to talk about what the solution is to all of this. How would you give, how would you advise the general public to avoid back problems in the first place?
Well, there's so many ways I could take that. The first one that comes to mind is when I was at the university, I would get a call from a corporation, say Goodyear Tire. Would you come down to Goodyear Tire and put in a prevention program for us? We have a carpal tunnel person. And I said, well, what did they do? Well, they came in and gave us a presentation. And I said, oh, and what's the change in your carpal tunnel incidence? And they say, well, we don't know. I said, I think you better measure that. So know your old statistics. And how are you doing now? Oh, they're worse. Yes, you've created a hyper awareness about carpal tunnel, so now it failed. And so anyway, I could take the whole conversation that way, or I could say in another tack, now I forgot my line of reasoning there. Darn, it was a good one. Anyway, it doesn't matter. Oh, I know what it was. Motivating the uninjured. Now let's go into Goodyear Tire, just to use them as an example. And I'm going to talk to you folks now about back pain. If you've never had back pain, do you think I'm going to be able to stop them from getting it in the future? No, they're just going to keep doing what they've always done. And remember, back pain is like smoking. It takes a while for the cumulative traumas, so to speak, to add up until they're clinical. But that didn't work in smoking. It won't be me that gets disabling back pain or shoulder pain or hip pain or anything else. So unfortunately, I have to let them get a little bit of back pain.
As a learning experience.
It is. The person needs a bit of context. Very rarely do you get a person and say, my mother went through hell. I don't want to be that person.
Sure.
Can you give me some advice? So occasionally you'll get that. And now you've got an ear that is receptive. But to motivate the uninjured or the unpained is a very difficult challenge. And I don't start there anymore. I tried for years. So now I just say, well, if you've got back pain, this will sound self-serving, but I wrote the book for a reason. It's a unique book. Please read Back Mechanic and understand that pain is not random. It's not non-specific. It's very specific. Here are 9 self-tests that you can do to at least get a rough approximation of, is sitting making you worse? Holding 5 pounds in front of you, does that make your back pain worse? So that's a compressive load. Maybe it's the way you train, doing 100 sit-ups every day. Well, if you just held a plank for 10 seconds times 5, your back pain would go away. And there's a reason for that. So The book takes the person through a self-assessment, and then it shows them what to do and what not to do based on their subcategory, gross subcategory of back pain. And then we get into what we call spine hygiene. How do you tie your shoes? How do you put on your socks and your underwear? How do you get on and off the toilet? And so we teach them things like a hip hinge squat, how to get onto the floor with a lunge, roll onto your back with a baby's crawl. It's jujitsu 101 for the martial artists, basically. There's only one efficient way to move. And then we get into tuning the body with strategic mobility and stability. Again, more common patterns, not super specific to an individual. And then by the end, they should be able to wind down their pain. The book stops. Then the second part is Ultimate Back Fitness and Performance. My next book, that's when the fun starts. I want to play golf.
Yeah.
Well, what do you do to play golf? Do you think getting your back stronger will make you a better golfer? No. When we measure the best long drivers in the world, they don't use much muscle. It is a timing, and it's actually a muscle pulse. Pulse, pulse. And so we teach pulsing exercises when the spine is neutral at ball impact and this kind of thing. So anyway, it's maybe a roundabout way, but that's the only way that I know of to bring a person along with good science and good effective coaching of the right thing for them.
Beautifully said. Beautifully said. And I can't recommend Back Mechanic enough. It's a phenomenal book, and I can tell how much went into it. And you write the way that you speak, which is one of the things that I love about it. I can tell it's you when I'm reading it.
That was the most difficult book I wrote. When I started writing, I wrote for clinicians. I wrote medical textbooks, which were easy for me. I would state facts, I would give references, I would be able to give lots of details, use a language and a lexicon that I was familiar with. And then a book publisher, it was actually a book agent from New York, came to visit me and said, I read your Low Back Disorders, which was my medical clinical textbook. Could you write something for the lay public? And I said, well, I don't really, I don't think I'm a very good communicator for the lay public. I write medical things. And she said, no, and we want you to have a title, Fix Your Back in 3 Easy Steps. And I said, in order to sell books. And I said, but that's not truthful.
Yeah.
It's not possible. I know there's lots of books and promises on the internet of that sort of thing, but it's not possible. And so Back Mechanic turned out to be 17 chapters with an assessment and, all the spine hygiene bit that I went through. And I'm telling you the story because that was the most difficult book I wrote. It took me 5 years. And the challenge was to keep enough scientific truth and integrity to it that it's actually helpful, but not so complicated that the average person can't consume the information and put it into practice. So that was the dance.
Well, I think you did a wonderful job, and I can relate to it because when I created my program, it was much the same. It started off as a book, and over 6 or 7 years, it kind of morphed into different things to the point where it became a self-guided instruction for people that are suffering with chronic pain. But being able to speak the language and give examples and take the science and present it in such a way that it makes sense. And then explain to people why they're doing what they're doing and why other things haven't worked, which I think you do a phenomenal job of.
Well, thank you. Yeah, I'm sure my English teachers from high school would have never thought.
So you also, Dr. McGill, you have some clinicians that you've actually trained, and these people are scattered throughout the North America or the world, or?
Yes, they're in Europe. We've got a couple in Asia. Well, not quite a few in the U.S., Canada, Australia, etc. And we have 2 levels. We have the certified clinicians who take our courses. They're now online. and they have to write an exam and then do an exam online with a patient in front of our, we have two master instructors who teach with me. But I don't practice with them. So they can pass the exam and appear to know what they're doing. But then we have an elite level called a master clinician. And this is someone who I have worked with personally. I've seen them work with patients, and I'm very confident in sending them some challenging cases. And they will get, I want them to get 18 or 19 out of 20 back pain patients better who walk in through the door. So that's the elite level of efficacy that I'm going to use a very strong word, but it's what I insist on.
Nice. And if people want to get in touch with McGill certified clinicians and practitioners, they would go to www.backfitpro.com. Is that correct?
Correct.
Okay. Fantastic.
Yeah. And so if the person is a clinician, they enter through the clinician's portal. If they're a person with back pain, they enter through that. And it gives them, there's all sorts of podcasts. I hope this podcast will be on there. We'll make those links, at least I won't, but the person who looks after it will. And there's some books and some articles and those kinds of things that will hopefully give them some good scientific guidance.
Fantastic. Well, I really want to thank you for taking the time and sharing your expertise with my audience. It's very much appreciated. As I said, I'm a huge fan of your work. It's been influential on me, and I very much appreciate it.
Well, Yanni, thanks for all you do, and thanks for all your support.
Thank you so much for watching. I really hope that you enjoyed this interview and that you'll put the information to good use. Make sure to like the video, comment down below, and subscribe to stay updated on the new videos that come out each week. Also, check the description. I'm going to include links for a couple of Dr. McGill's awesome books, as well as contact information for BackFit Pro, where you can find out more about the incredible work that Dr. McGill and his team are doing. Thank you so much for your support. We'll see you next week.